in heavily water damaged buildings, it's not just mold toxins. There are other inflammagens, microbial volatile organic compounds, man-made volatile organic compounds. They all enter the mix. There are fungal fragments, bacterial fragments. So anybody can get pretty sick in a building like that. But in what's commonly referred to as mold toxicity syndrome, about 1 in 4 people carry these HLA genes. HLA means it's on chromosome 6, and it has to do with the part of the immune system that presents antigens from one cell to another, processes those antigens first, and begins this process where you can acquire a coordinated cellular and antibody response against something like this should you come across it again.
Hi there, welcome back to High Intensity Health Radio. This is Mike Mutzel. I'm so grateful that you're with us. Today is episode number 52, and we're going to catch up with integrative medical expert Dr. Keith Berndtson to learn all about mold and mold toxicity and how to assess mold toxicity, not just in yourself, but in your home, your school, or potential workplace. So he's going to dive through all the details in so much more detail than I ever even imagined. I mean, this is a really complex topic, and I think a lot of people that have fatigue-related issues, cognitive issues, sleep issues, if you're one of those people that you've bounced around to a bunch of different doctors and you can't seem to get help, I think you might really enjoy this because he's going to provide some additional level of testing that I've never even heard about, and I've been doing this for 10 plus years. So I think you're really going to enjoy this. Now, if you're listening over in iTunes, you can hop on over to YouTube and actually watch this. Now, if you're on YouTube and you want to listen to it, you can go over to iTunes, and that's just High Intensity Health Radio over in iTunes. So I really hope you enjoy this episode, and we're going to catch up with Dr. Berndtson again to learn about Lyme disease in just a few weeks. So if you like his presentation style and his level of detail, then you're certainly going to want to pay attention to that one. So I would encourage you to subscribe over on iTunes or YouTube if you haven't already, and I hope you enjoy this episode, and we'll catch you on the next video.
Very excited to be with you, Dr. Keith. How are you doing today?
I'm great. My pleasure.
Fantastic. So let's open up the can of worms on mold and mold toxicity. We were talking before we started recording.
You sure you want to do that?
Yeah.
No, there's a great need to do it. People often want to know how I got into this, and back in 2007 when I had opened this practice, a patient walked in with this book called Mold Warriors by some guy named Richie Shoemaker, and I finally got around to opening it and reading it a little bit, and began to feel like I was drinking from a fire hose because there was so much information in it. A lot of pathophysiology, but also getting into patient stories and legal ramifications and implications for agricultural practice, construction practice, remediation and inspection and cleaning and all that kind of stuff. So I wondered what I got myself into, but I then subscribed to the newsletter from Surviving Mold, his website, which now gets about 3 million hits a month, and builds up my confidence to start taking these patients on. And even at that point, I was kind of at the lower end of the learning curve. But what's important to understand here is that this is not just about mold toxicity. Back in 1973, when there was an OPEC embargo and there were long gasoline station lines and so forth, there was a premium on conserving energy. And so builders decided they would step up and they would start building homes that were pretty tightly sealed, and you could trap heat and save money during the winter and all that.
Sure.
But created conditions where moisture had nowhere to go. The buildings weren't breathing the way they used to, and so we started to have more of what's called sick building syndrome, which in the beginning wasn't very well understood and kind of got laughed out of the room in a lot of grand rounds and that sort of thing. But now we know much more, that under certain recurrent moisture conditions or after water intrusion events, roof leaks under sinks, flooding, of course, flooded basements, that molds can get a leg up. And, all molds need to grow is moisture and cellulose. And dust contains cellulose. So pretty much have growing conditions almost anywhere where there's been enough moisture. So it's very important to discover these intrusions and remediate them quickly, because within 48 hours you've got mold growing. Now, not all molds are toxin producers either, but the ones that are have genes that code for toxins that they use to defend themselves when they, pick up stress signals. And that could be running into man-made chemicals in the drywall, or whatever. They make spores that carry toxins. When things dry up, the spores go dormant. But when the moisture returns, they become active. They could be spitting out toxins. In heavily water-damaged buildings, it's not just mold toxins. There are other inflammagens, microbial, volatile organic compounds, man-made volatile organic compounds. They all enter the mix. There are fungal fragments, bacterial fragments. So anybody can get pretty sick in a building like that. But in what's commonly referred to as mold toxicity syndrome, about 1 in 4 people carry these HLA genes. HLA means it's on chromosome 6, and it has to do with the part of the immune system that presents antigens from one cell to another, processes those antigens first, and begins this process where you can acquire a coordinated cellular and antibody response against something like this should you come across it again.
Sure, okay.
But in 1 in 4 people, there are now 12 genes that have been identified, 12 HLA genotypes, that render people susceptible to poor clearance of toxins made by living things, or biotoxins. In the category of biotoxins, mold toxins account for 80% of the clinical problem. But bacteria can generate toxins, parasites, fungal strains that might colonize mucous membranes, also capable of producing toxins that are nasty. Candida albicans, for example, has been shown to make something called gliotoxin. It's called gliotoxin because it can find its way into the microglia of the brain and disrupt things. And we know that many of the mold toxins that have been described are cytotoxic as well. They can arrest cell cycles, they can arrest mitosis, they cause oxidative stress, they cause ribosomal stress. So they're bad actors.
Yeah.
And if you're one of those 4, or 1 in 4, who has a hard time clearing these things, you become sick over time. You might not on your first exposure, and in many people it seems to require a priming event of some kind, like a major stress or an accident or a bout of mono or something like that. And once that's happened, the next time, now that your immune system is primed to marshal a big response, next time you're exposed to biotoxins, it's going to start to cause this inflammation, because the complement system, which is part of the innate immune system, it's genetically programmed to respond to dangerous molecular patterns that we've been exposed to over the eons through our ancestors. And most of them come from microbes, right? So there's one complement protein called C4a. This is the activated form of C4 that seems to specialize in responding to toxins made by living things. So when you've got these toxins in your body and you've got the genes that make it hard for you to clear them, C4a is responding to this again and again and again like it's seen it for the first time. And when that happens, it initiates a cascade of downstream inflammation that ropes in a bunch of other markers, but not sed rate, not C-reactive protein, not the classic markers of inflammation that we see.
Sure.
Things that are unfamiliar to many people, like they were to me when I first learned about these things, like TGF-beta1, MMP9. There are 3 types of hormones known as regulatory neuropeptides that are made in the hypothalamus that get roped into this problem. One is called antidiuretic hormone, or vasopressin. It tells the kidneys to conserve water, and so when it's not getting synthesized, and when we measure it, it's often undetectable. That means the kidneys are not getting the message to conserve water, and you wind up getting dehydrated. And if you get dehydrated enough, then you become symptomatic. You're thirsty, you're drinking water like a fish, but you're peeing it out at about the same rate, so you're not gaining on it. At some point, if the osmolality, the electrolyte concentration, goes up high enough, you may become a static shock machine. Right, and so that's actually one of the symptoms that can provide a tip-off that something like this is going on. So antidiuretic hormone, then there's something called MSH, melanocyte stimulating hormone. I know everybody gets tripped up on that one because, they name these things for whatever they find it doing when they first discover it.
Right.
But in the immunology literature, alpha MSH is viewed as a field general coordinating immune defenses for mucous membranes in the body. So the respiratory tract, the gut, the urinary tract, and the skin is also involved here. So we know that synthesis of MSH, it's actually not a synthesis issue. It's MSH is bound to something called POMC. It's pro-opiomelanocortin. And when leptin, which you know plenty about,
Sure.
binds to its hypothalamic receptor, it initiates downstream pathway activation, including a process that would cleave POMC from MSH to free up MSH.
Okay.
Well, and POMC gets cleaved into melatonin and beta endorphin.
Oh, wow.
So if that's not happening because the leptin receptor is partially blocked by pro-inflammatory cytokines, then you're at risk for not sleeping as well, for having your pain feel amplified, and not having this field general coordinating mucous membrane defenses for you.
Wow.
And then the other one is called vasoactive intestinal polypeptide. So those are the three regulatory neuropeptides that can get involved in this chronic inflammatory response syndrome that we call SIRS. Chronic does start with a hard C. SIRS is a soft C, but if we use the hard C, it would be curse, and that just seems like piling on.
Right.
They're sick enough already.
Sure.
So vasoactive intestinal polypeptide is a really big player. I mean, it's considered a master regulator of immune function and a master regulator of blood flow distribution in the microcirculatory regions of the body. So, and when VIP is approaching the undetectable range, it's not uncommon for these patients to have unusual shortness of breath, air hunger at times, and at some point they get chest pains because they're trying to breathe so hard just to oxygenate. And what we find is that when TGF-beta 1, which I mentioned earlier, is active enough, it can start causing remodeling in the areas that are inflamed. And if it's airborne toxins, the first place where inflammation starts is in the lungs and in the bronchial tree. So what TGF-beta has to do is remodel, and that often results in a little bit of fibrosis.
Wow.
The fibrosis involves the arterioles in the lungs, so they narrow. And that puts increased pressure on the right side of the heart, which is trying to take this deoxygenated venous blood and send it back through the lungs so that it get into the left side of the heart and then back out and around the horn. So what happens when you've got this back pressure is really it becomes an acquired form of pulmonary hypertension. And this is a new understanding of a form of pulmonary hypertension that is both theoretically reversible and in practice and in most cases reversible.
Wow.
Because people go online and read about pulmonary hypertension and it almost reads like a death sentence. And this is good news. If you've got pulmonary hypertension but it's this kind, it's good news because this condition is treatable. There are several other markers as well. So if we want to make the diagnosis, what you need are three things. You have to have a multi-symptom illness. If you've only got 3 symptoms, you don't have this problem.
Now explain that a little bit so listeners can understand that better.
So Dr. Shoemaker has kept data sets for 16 years or so now. And one of the things he did was track symptoms in people. And as he started piecing together pathophysiology, and he came close to diagnostic criterion for the diagnosis. And he found that among 37 or 38 symptoms, that patients had 23 on average, whereas healthy controls had 3 out of, I think it was 37 symptoms. And so you may, see visible mold in your home, you may smell mustiness. You come in and tell the doctor you're mold toxic, the first question is, well, fill out this symptom form. And if you've only got a handful of symptoms, it's not very likely that you've got this problem. Because we know what happens when it gets unleashed.
Yeah.
You can't have fewer than, a dozen symptoms at least. So a multi-symptom illness, then we want to see that you've got at least one of the 12 HLA susceptible genes, meaning that you're not going to clear these toxins very well, so you're going to stay inflamed because you're retaining them. And then we want to see, genes load the gun basically, they don't pull the trigger. You need the markers of exposure to show that the trigger's been pulled and you've got this kind of inflammation. So imagine being one of the patients that we commonly see in this field who's been to a half a dozen or more doctors, and it's usually allergy, immunology, possibly ENT, neurology, psychiatry, rheumatology, and each specialist is got in-depth understanding of their field, and sometimes they'll find reasons to do their workups because they've got enough suspicion, but they still can't fit them into anything. And then occasionally they will, try to fit them into a shoe that doesn't quite fit.
Sure.
Try some treatments because the patients are desperate, but the treatments don't work out.
So we're talking about the symptoms. You mentioned that if you don't have more than, say, half a dozen or a dozen somewhat symptoms, let's go through some of these. We mentioned autoimmunity. But let's talk about maybe headaches, migraines, things that people may experience that may lead them to a test.
Among the most common would be fatigue. And I mean, the severe fatigue where it becomes really hard to function. People soldier through as best as they can until the point comes where, they can't work anymore. And that's often accompanied by disrupted sleep. We think what happens here is that the toxins and the inflammatory cascade that won't shut off start to wear out the buffers against anxiety and depression, and that are needed to help you orchestrate normal sleep. Serotonin and GABA chiefly. But there are other inhibitory neurotransmitters that are breaking against this constantly, and they can't keep up. Well, when those brakes wear out, then you're stuck in a state of excitotoxicity. The brain is staying in this excitatory state when it should be giving way to sleep chemistry. And so, that's part of what makes them tired. And the inflammation always creates a yellow alert signal to the brain, so that, that keeps the slider up toward the excited part. They develop neural excitability manifested by increased sensitivity to light, harsh sounds, sometimes even tactile sensations. So they're very excitotoxic. So along with that goes anxiety. And sometimes it, for reasons not so clear, will manifest as panic or as OCD, anything on the anxiety spectrum. And of course, when they're seeing doctors and they're not coming up with answers and they've got all this anxiety, you know where they're headed.
Right.
And they go on medications, and it may move the slider a little bit, but it's not getting at the root cause. The other thing that gets roped in is cognition. So they start noticing that they're falling behind on some of the higher order cognitive processes like multitasking or executive function, which is, being able to be organized and get through a series of tasks from beginning to end without getting too distracted or losing your way. Then they may notice word finding issues, difficulty with recent memory, but also memory consolidation. The things that you learned yesterday you can't recall today. Circuits are not working the way they're supposed to, and they often involve these frontal lobe subcortical circuits. There's a whole series, 5 to 7 of these circuits that can affect motor function and emotions and cognition. We'll even see some of the subcortical structures get involved when we do a kind of MRI image processing called neuroquant. This is a very interesting technology that has a lot of potential. What we find is that when you take a standard MRI image without contrast and run it through the neuroquant process, they remove the valleys. The brain has the peaks and the valleys. They remove the valleys, and then they inflate it into a sphere so that all the brain regions register on the same sphere, and they analyze the volume of brain centers right to left. And there are patterns that are showing up, patterns that say Alzheimer's or traumatic brain injury or PTSD, or because Shoemaker's developing enough cases, and we're going to start doing some of these ourselves, you've got Lyme or you've got mold, or you've got a pattern that suggests maybe both. So, but it just goes to show that, what we see is enlargement of some centers and shrinkage of others. And the enlargement appears to correlate with a process called microinterstitial edema. So it's a micro swelling. You don't see it on an MRI because that's a macro image. A radiologist's eyes can't pick that up. But when you spherify something and do the math on it, you can see that there's swelling there. And if there's shrinkage, it usually means that there's a decrease. This is for the clinicians out there. Yeah. Decreases dendritic pruning and neuronal regrowth. But both are reversible. We see it happening. All right. So these cognitive issues and the sleep and the mood issues and the fatigue and so forth, almost always reversible. All right. So we've got fatigue, we've got sleep issues, we've got anxiety, depression, sometimes OCD, and then we've got cognitive issues. Headaches, headaches that seem, very migraine-like, headaches that are focused between the eyes at the bridge of the nose, sinus involvement, tension headaches, they're all part of the mix. I mentioned the sinus headaches. One of the things that associates with heavily water-damaged buildings is growth of a type of staph called coag-negative staph in the deep nasal space and in the sinuses. Now, the interesting thing here is that coag-negative staph has been viewed as a normal commensal bacteria for decades. Insurance won't cover a swab for it because it's, but they're not keeping up with the literature clearly, because we know that this kind of coag-negative staph can be multiply drug resistant. It's been shown to make an exotoxin. That's a toxin made outside the body technically, but gets absorbed into the mucous membranes. And guess what this thing does? It seeks out MSH, the field general coordinating the defenses against it, and assassinates it. cleaves it. All right, so nature is selecting these mechanisms for these microbes, perhaps to take care of the human problem, but sometimes wonder which side to be on there.
Wow.
And it does other things too. It participates in biofilm communities. A lot of people are hearing about biofilm now. It's a particular kind of structure, and it's based on this notion of quorum sensing. So if there are enough bacteria and fungal strains and anybody else who's got genes that can participate, when they sense that there are enough of them, densely packed together. So, I can empathize with physicians who might not trust the validity of these things and, are hesitant to kind of, step into the ring because I felt that way myself. But, once you get into the current of it, especially if you start trying to back it up with your own PubMed searches and so forth, you find that this is extremely valid. It's very prevalent. We can only guess, but NIOSH, the National Institute for Occupational Safety and Health, estimates that 50% of the structures in the country have suffered water intrusion. All right, now there are 315 million people in the country. So if it's 1 in 4, let's just say 80 million are susceptible. Susceptible. 50% of the buildings have been water damaged. All right, so let's say 40 million, but then let's be conservative and say 10% of those buildings, harbor the growth of toxic molds and other inflammagens. It's still 4 million people, and that's about half as much as the undiagnosed diabetics out there. So this is a big problem.
Right.
And there aren't that many doctors. I mean, Shoemaker is starting to certify doctors, and I was glad to see what a rigorous process it was. I mean, I was pulling my hair out during it, but what's left of it. But you can develop a lot of confidence and help a lot of people by getting into this. And I would just forecast this too, that when regional health systems that are preparing for a global payment in advance model realize how much cash they're burning on specialty workups that aren't helping people like this, they might want to have somebody with this kind of expertise in-house because they'll burn less cash. And if you're stepping up to global payment in advance, you've got to be a master at expense control. So just putting that out there.
Yeah, that's great.
So to assess people, we they have to have enough symptoms. That's hardly ever a problem. We check them for the HLA genes. If they've got at least one, then we know that they're susceptible. And we look at the markers. We look at the C4A, the TGF-beta. We look at those regulatory neuropeptides. A couple of others I didn't mention, C3A and VEGF, or vascular endothelial growth factor. That can be high or low in this condition. Just to get a clear idea as to whether there's enough of a pattern of this particular kind of inflammation to make the diagnosis. And once we make the diagnosis, patients are thrilled. Finally, they've got an explanation. Then I proceed to describe treatment, and their hearts begin to sink again if it's their house or their workplace or their school that's affected, because the only way to get started with treatment is to remove yourself from ongoing exposure to sick indoor air. The reason being, we've got binders for these toxins. They came on the market to lower cholesterol and to bind bile salts. Cholestyramine and Welchol, they each contain quaternary ammonium. That's a chemical group, the nitrogen in which has a positive charge about the same size as the negative charge in most biotoxins, and so it does a great job of binding these things. And each dose is like a bus full of empty seats waiting to be filled up with toxins and get shipped out of the body.
Wow.
But if you're going home or you're going to work and you're just getting another ingress, you're not getting anywhere.
Sure.
And sometimes you're mobilizing toxin in the process. When you start shipping them out of the body, instead of recirculating them, what's happening is you're shipping them out. And so the more loosely bound toxins in the system get drawn into the circulation. Now you've got a higher concentration in the circulation than you're used to. So the inflammation's higher.
Man.
And if you've got that going on plus ingress, you feel worse. And you're cursing the day you ever followed my advice, right? So how do you remove yourself from ongoing exposure if you don't have the funds to even do a mold inspection, let alone remediation? Or, how do you approach working with a school district or an employer or a landlord about this issue? What I've seen time and time again is that the property owner or the school board or whatever will quick get a remediator to come in and do an air sample, spore trapping or something, and come away with the conclusion, what are you talking about? This building is fine. And I come back and say, well, from the industry standard, okay, that's fine. But, I'm a physician treating ill people. What predicts who can get better and who can't in a given space is the environmental relative moldiness index developed by the EPA. A lot of remediators don't like that test, but that's for their purposes. I have to have it for my purposes. They sample dust, they look for mold DNA, they amplify it. When they find it, and they can tell exactly what species it is, they'll put it into a toxin-producing category or a common non-toxin-producing category, and they'll come up with a score between -10 and 20. And what the data sets show is that if you've got a score of 2 or above, it's going to be very hard for you to get better in that building, taking cholestyramine or Welcome. And so then I'm forced to tell people, well, you can remediate and clean, move, quit your job, go to a different classroom, drop out of school, or get worse. And they're going, oh man, now I don't wish I had this problem.
Wow.
Right? So there are social consequences. Family members who don't want to go through the stress of all this, on something that's been substantiated by one doctor, right? I've seen marital discord. I've seen divorces. I've had a couple of patients who have lived out of their cars, or one found a good Samaritan, pitched his tent in the middle of last winter, which was a horrible winter in Chicago. I mean, horrible. Yeah. So he's lost his marriage, got kicked out of his in-laws' house, slept in a tent on a deck in the middle of winter, and started breathing normally for the first time in years. I would make this appeal to physicians who are seeing patients with multi-symptom illnesses. Just because the labs you've done don't explain what's going on with these people, don't assume that they've got a somatic symptom disorder or that they're depressed or anxious. There are labs that show what's going on. They're not making this up. An additional cross for them to bear is to be told that there's nothing wrong, or that they're just depressed, or that they've got some secondary gain going on. Understand that there are doctors who are familiar enough with this stuff that know how to help patients navigate this difficult path. But once you get away from ongoing exposure, you start using the binders, it's a matter of weeks to months before you start feeling better. As the toxin carriage goes down, the inflammation goes down. As the inflammation goes down, the body's pathways start getting the band back together. We don't have to do a lot of fine-tuning. It just starts to come together. But it's a grueling process, where, you've got to deal with the legal implications and remediation. My opinion on that is get a mold inspector who's at least open to why I need an ERMI test, who can examine for visible mold and use moisture meters and infrared and whatever, and do a good casing of the house, come up with a conclusion, which may or may not involve a remediation plan. But if it does, let the mold inspector write it so that the remediator does what he's suggesting instead of remediators that can come in. And I know there are a lot of reputable remediators out there, but there are some who are not. They'll just insist that you need the works, and you really don't, and it burns a lot of cash. So this is a growing, very prevalent problem. With big weather, there's going to be more water intrusion events. And these people are wandering out there. They're bouncing between specialty silos like pinballs. And they go online, or they hear from a friend that here's a doctor who might know how to deal with this stuff. Maybe you've got this, go check it out, and we'll sort it out for them. And the treatment path may be complicated, but with the right kind of support, most people are getting better.
Yeah. Fantastic. What have you found to be effective on the nutritional side? So we're using the cholestyramine, bile acid sequestrants. On the pharmaceutical side, anything in particular to support the immune system?
So the toxin mobilization creates a symptom intensification. We equate it with a HERX, that's technically not a HERX, it's a different thing. That's an antibiotic showing your immune system where the action is, and you feel worse for that reason. But we think of it in terms of HERX moderators. So magnesium makes a big difference. We find that curcumin, especially the bioavailable forms,
Sure.
Glutathione, alpha-lipoic acid, a sustained release alpha-lipoic seems to work better than plain alpha-lipoic. Epsom salt soaks, Alka-Seltzer Gold. There are some homeopathics and botanicals out there that can help a little bit. And you know, the lifestyle medicine, you know, doesn't become a non-issue here just because they've got this condition. You know, they've got to get plenty of vegetables. You know, our cells have figured out how to solve lots of problems using phytonutrients, you know, that come in through the diet. And I described earlier how much these toxins can mess with cellular metabolism. So, and then, you know, decrease junk and fried foods and so forth. You know, the usual litany.
Yeah.
I hear some people doing better on a paleo or a modified paleo. Some people, you know, on a lower carb. Some people on you know, vegetarian or vegan. Others are doing the FODMAPs diet and so forth. And it's unclear at this point whether a particular approach to diet helps more than just avoiding junk and getting whole foods.
Okay.
Exercise is an issue for them. They have to approach it very carefully. They've got a decreased anaerobic threshold, so when they push it too hard, they can crash for a couple of days, just like a chronic fatigue syndrome patient. At the same time, we want them to do something for 5 minutes, you know, for a week, and if they tolerate it, then, you know, see if you can make it 10, and then. You know, it might be with hand weights or stretches or something like that to begin, and it might turn into something mildly aerobic over time. But it just doesn't work very well until you get the inflammation down.
Sure. That's great.
But that's a good question because, you know, we should never forget that the foundational stuff.
And as we wrap up, so there's so many different labs here, from HLA-DQ and MSH, leptin, VIP. Is there one package or panel? So if someone does have all these signs and symptoms and maybe doesn't have access to a astute practitioner like yourself, but they could work with a practitioner to get some of these testing done, is there any go-to?
Yeah, you need the genetics. HLA-DRB1, HLA-DQB1, and HLA-DRB 3, 4, and 5. I'm sorry, I didn't invent this nomenclature. This is why we use the Rosetta Stone to translate it, but you need that. You need a TGF-beta and a C4A. You know, that's the bare minimum.
Okay.
If the C4A is high and the TGF-beta is high, we know that something's going on. C4A reacts to biotoxins. TGF-beta can be elevated for two reasons. One is it's trying to suppress an overactive immune response, like an innate immune response that cannot get out of this loop that it's in. That's in the bloodstream. In tissues, TGF-beta seems to activate Th17 cells, which are like cytotoxic T cells. So when we see a high TGF-beta1 level, we can't apportion, you know, the relative contributions of those two. But it doesn't matter. We know that that's a problem.
Yeah.
Either way. So, you know, we like to follow some of the other markers to gauge progress, but they are expensive, and, you know, usually insurance is covering them. We haven't had any pushback, except for the very tiny insurers who have to push back against everything.
Right.
Yeah, the HLA genetics and C4A TGF-beta, that's enough to kind of decide whether you're in this category or not.
Get the ball rolling. Now, what companies package that together? Do you have any go-to that you recommend?
Well, I use Quest only because they've worked so hard with me to make sure that the difficult draws get processed properly.
Oh, okay.
You know, if you walk into any old phlebotomist with one of my orders, you'll see the blood rush from his or her face. You may have to pick them up off the floor,
right? Because
there are like 5 frozen specimens that have to go on dry ice, and then there's a tricky double spun processing that has to be done on the MMP9, and so We spend a lot of time working with Quest on this, and they've been very responsive to every little wrinkle that we throw at them.
Great. That's awesome. So as we wrap up here, Dr. Keith, how can practitioners and patients learn more about your work, your website, and how can they contact you?
Well, you can go to Park Ridge Multimed. I've got some slides posted under mold toxicity. There is some overlap with Lyme too, because we know that Lyme spirochetes have plasmid DNA, and that seems there's at least one study that identified a toxin that they can produce. Bacteria and fungal strains produce toxins in their own defense. But if you've got Lyme and you've been treated with aggressive antibiotics for a long time and you're not getting better, we have to wonder if it's because you're not getting rid of the biotoxins that they made. And you may have beat Lyme into submission, but the reason you're still sick is, we've got to deal with a second thing, this inflammation that's caused by biotoxin retention. So those nuances are covered on the website. Park Ridge Multimed is taking these kinds of patients, so people can call to schedule, learn more. There's a lot of information on survivingmold.com, Dr. Shoemaker's site, especially for physicians who are interested as to whether they might want to get into this or not.
Sure. It's really great. That's survivingmold.com.
Survivingmold.com, right.
Fantastic. Thanks so much for being here.
My pleasure.